And we're live. Good morning, good afternoon, or good evening, depending on when you're watching. Glad to be here on LinkedIn and YouTube. This is the Healthcare Leadership Show with Marion Spears Carr. That's me, your host, and truly honored and very excited about today's conversation. Today's topic is pharmacogenetics isn't the future, it's now, and how you can use it today. And my guest is CJ Michaud. He is a clinical pharmacist and just got such a great background, infection disease background. He specializes in molecular medicine. He's an expert in PCR and PGX, which we're going to talk about, interpretation and clinical utility. And he has this background really from formerly in the cardiac ICU transplant pharmacy space. CJ, welcome to the show. So glad to have you. He's director of clinical operations for Aegis Health Services. CJ, introduce yourself better. I'm so glad to have you on the show. And we've had such a good opportunity to learn from me around this topic. And I would love for you to introduce yourself, and we'll just jump right into the conversation. Welcome to the show.
You bet. You bet. Yeah, it's an honor to be here. Thanks a lot for having me. Yeah, as you mentioned, CJ Michaud, clinical pharmacist, dual board certified, pharmacogenomics certified. And yeah, I got an interesting sort of path through clinical pharmacy. I started out in the inpatient side, doing cardiothoracic medicine, infectious disease predominantly. And it was through that some of these molecular tools about 15 years ago, 10 years ago, started popping up more frequently, helped to bring some of those molecular diagnostics into the inpatient environment and to our health system space, outpatient spaces as well, both on the infectious disease side and then on the pharmacogenomics side and on the PGX side of the platform, helped to build our health system sort of pharmacogenomics program, both inpatient and outpatient. The way that, if you're familiar with pharmacogenomics, maybe you're familiar with that sort of health system model of the clinics and calling patients and getting test results in and explaining how this works, kind of provider and nurse and pharmacist, the whole healthcare team together. And then that's what allowed me to sort of explore more this molecular space and start to bring it to other health systems and educate about it and work with CPIC and some of the other guideline forming groups. Because if you are at all familiar or inside the pharmacogenomic space, you know that it's just exploding. And it's really evolved quickly in the last 5 to 10 years to really become, I think what we're talking about today, a tool that is really available to a lot more people who then may realize it. So I'm really excited to be here with you today to talk pharmacogenomics.
Well, and very excited to have you. And I've learned so much working with you and working with the team at Aegis and trying to understand the impact that having a pharmacist, having a clinical pharmacist, working with the other care providers, the physicians assistants, APPs, et cetera, in understanding how this will make the patient's lives better. That's awesome. And I want to get into that piece of the conversation in a moment. For those of you watching live, or if you're watching the recording, a lot of people that watch my show, please let us know in the comments. We'd love to hear where you're watching from. And if you have questions for CJ, put them in the chat. And one of the things about my live show is there's always conversation going on in the chat. So pay attention to that, the comments. Let us know where you're watching from. We're glad to have you. And if you've never seen the Healthcare Leadership Show before, this is my weekly show on Tuesdays at 12:30, where I introduce and interview people that are in my network that are doing great work to my network and beyond. So CJ, for those leaders, and most of my audience are healthcare leaders and hospitals, physician practice groups, bioscience side of the house, give us just a little short primer on what really is pharmacogenetics. Because one of the things you and I talked about, and I love this analogy that you shared, is how X-ray, when it was first introduced, it wasn't early adopt, like there wasn't this mass adoption for using for diagnostics, right? And it took understanding and awareness and learning before it became just normal part of the diagnostic process. In the same light, I've learned through you and through the team that PGX is the same way. So maybe give us just a brief little primer of what that looks like, what that process looks like, and then we'll jump into why this really matters and why it's available now.
Definitely. Yeah. Most, if you're not familiar at all with pharmacogenomics, the 30-second primer is that, yeah, this is our way into the personalized medicine era, the precision medicine era. Because for the first time ever, we're able to actually sort of map an individual's genome, if you will, or at least the parts of it that interact with drug metabolism, to understand that, sure, a guideline may say this SSRI, for example, is the first line agent for treating depression. And for a lot of people, that's probably true. But for some people who have enzymes that work either way overdrive or they don't work as well, that medicine won't be appropriate, or that patient either won't get the benefit of that medicine, or they will be at higher risk maybe for toxicity of that from that medicine. And that's what this test allows us to do. Unlike a lot of things in the genomics world, or not the genomics world, sorry, the diagnostic space, pharmacogenomics is kind of unique in that your genetics are your genetics forever. So this is a one-time test that pays dividends for the rest of your life. And that's where a lot of the data is now, is exploring doing this earlier in life, because your genetics don't change. So if we realize that you have a different type of functioning enzyme, that can impact your medical choices for literally the rest of your life, to improve the benefit that you get from medicine. So it's such a unique field in that way, but it can have such a huge impact. And the payer side of the world, the broader medical community is starting to realize that. And so that's why we're seeing it employed in all kinds of ways. And I see Robert in the chat talking about companies that streamline results to prescribing platforms. There's different platforms to get integrated with EHRs and make this information more available. I mean, there's such a huge expanse of ways to innovate in this field, to bring this really precise patient-specific medicine to the masses. And that's what I'm really passionate about as well, particularly from the clinical side, making sure that people who are not necessarily genomics experts or DNA experts. I talk to extremely accomplished physicians who say, I haven't thought about that since med school, and that's true. None of us have.
Yeah, right.
But that's the idea corollary with the radiology that you bring up, that X-ray and these things this technology came about, but it was 30 or 40 more years of just sort of freewheeling it before we realized we need dedicated specialists who we're going to call radiologists. And the field of radiology wasn't even really formalized until 40 years after the technology was sort of out there. And I don't want to see us do that same thing with pharmacogenomics. I don't want to see it just sort of flop around for 40 years before we realize we just not everybody needs to be an expert in pharmacogenomics. We just need some people to be experts to allow all of us in medicine and all of these patients to take advantage of it. So that's what I'm really passionate about. And that's what we do at Aegis Health Services. Yeah.
I love that. And you shout out again, like you said, Robert Rupert checking in from Dahlonega. Thank you for the chat that's going on. Again, this is what I love about my show. My show is different than any other podcast you'll ever see, because the show is on the screen, but the learning is in the comments, and a lot going on over there. Doug's checking in. He's responding. I know Doug's down in Atlanta. Elia, I know I'm mispronouncing your name, just like I did yours earlier, CJ. My North Carolina accent getting in the way again. Checking in from Brambleton, Virginia. Jason checking in from Decatur. If you're watching live, or you watch the comment, or you watch the replay, please let us know in the comments where you're watching from, because it allows me to understand who are we talking to, who are just there. We go. We dropped for a moment. I think we're back up. CJ, one of the things you and I talked about was you've already hit on this technology that doesn't need to be, like you said, just kind of out there and people use it randomly. It needs to be part of the process. It needs to be kind of built into the clinical diagnostic world and the patient care management. One of the things I learned from you is the value of having the molecular pharmacist, the person with that training, your training. It's not just a technology approach to solving the problem. It's not just AI that's going to look at all the different drug therapies that are going on and do some kind of alignment of these are better, et cetera. There's a human involved that is available to be a part of the care delivery team that brings that expertise to the clinician and to that market and to the patient experience. Could you talk a little bit about how that human component and that knowledge base and working individually with the group into the care delivery model is the differentiator here? Because I think that's so important.
Absolutely. And that's something we need to continue to focus on, I think, as this field grows, because it has made very quick work of utilizing the sort of scientific resources around us. We all know there's platforms everywhere that list millions of drug interactions and millions of drug food interactions. And there's so many databases of scientific info that can be added in. And we see this in most of the labs that do this testing. If you're familiar with this, if you've ever been on the receiving side of a pharmacogenomics test, it could be 60 pages long because there's just so much textbook information to say about every one of these potential little risks, some of them severe, all the way down to the mild. And it's overwhelming. It's too much information in a lot of ways. And it actually gets in the way of being usable and being applicable at the bedside for these patients, because there's so many. And again, like we said, so many of these providers are not genetics experts. I mean, very few of our medical providers in the United States would consider themselves medical genetics experts. But that's why really this whole field is really actually right up the clinical pharmacist wheelhouse. And that's where the art piece comes in. And I think pharmacogenomics, like a lot of areas in medicine, is part science and part art, and knowledge to sort of tie all of that together and pull out the right pieces to do good for a patient. And to be able to break down a 60-page report with 100,000 little tidbits of information on it and break that down into 3 or 4 actionable ways that we can improve this patient's care, I think is directly in the clinical pharmacist wheelhouse. Because a lot of this type of information is what the pharmacists are dealing with every day in terms of sifting through all of these known risks and trying to figure out which ones actually are worth intervening on. And now we add the genetics component in, where, again, pharmacists are uniquely educated, I think, and positioned to, working with these enzymes and understanding the pharmacokinetics and dynamics of all of these drugs. This is really right up a lot of their wheelhouses, our wheelhouses. So it's a great place for us to fit into this, because that's what the providers ultimately need as well. Ideally, is somebody to interpret all of this data and sift through it to figure out what actually is going to be important to do for this patient. And that's where the reports that directly come from the lab, or the AI tools that are evolving to try and help, sift through some of this, just can't quite replace a human clinician who can factor all of that textbook data and all this patient data and all this laboratory data, put it all together into actionable, genomic interactions and interventions. And so again, that's what our team really aims to do as a fleet of molecular pharmacists who are trained in pharmacogenomics.
Yeah, and I love that. It's taking all this information and putting it into a format where the clinician, the physician, the PA, the nurse practitioner, and the massive volume of the care delivery team can put it into action to make and address it quickly. And I love the idea that you talked about earlier around once we do the PGX, once they do the test, once a patient has that test on, that data doesn't change in terms of the genetic side. And then you can build on that moving further. I like the fact, and hopefully I don't have to be a patient anytime soon, but I would like the fact that I have a higher probability as a patient if my care delivery team, the people I'm working with, are going to prescribe drug therapies that have a higher probability of being successful for me in terms of my care and my deliverable, rather than, well, we're going to try this drug, and if it doesn't work, we're going to try a different drug. Right. Could you give us an example of that? Because you and I talked about that. I love that idea of taking all this information, using the knowledge that the clinical pharmacist has at their awareness and understanding, and really drill down. Can maybe give us an example of what that would look like with a patient? Because I know that's a little bit off track from what we're going to talk about. But I think for our audience, I think it's really important.
Absolutely. How does this impact care, and what are the tangible examples? I mean, that's what this really boils down to. And there are endless examples. I mean, you mentioned trial and error.
Yeah.
Probably no area in medicine does that apply more than in the neuropsych realm.
Yeah.
Whether you are 5 years old or 95 years old, if you
Mhm.
need an antidepressant, an antipsychotic, an anti-anxiety agent, the best experts in these fields are ultimately saying this one is probably our best guess that will probably work for you. And we're going to have to
Mhm.
wait about 4 weeks to figure out if it's working for you, because these are slower acting agents and they take a little bit of time to build up. And it is no surprise to anybody listening, I'm sure. Patients will spend 3, 6, 9 months figuring out which drug to be on and which dose is the right mix of side effects and efficacy. And a lot of data has focused on this. I think the number I saw last was 71% of empirically prescribed antidepressants could be prescribed better on that first go around if you had pharmacogenomics data available. Because so many of these neuromeds go through these enzymes that are tested. And I see results every day that say that Zoloft that you're on, it's never going to work. You are an ultra rapid metabolizer. As soon as your body absorbs that medicine, you chew through it and it's gone. So you've spent the last 6 months titrating up on doses and trying more things and wondering if it's going to help with just a little more. It's not. It's never. And 6 months ago, we could have told you that about this person, and we could have told you what med is going to be better. So the neuropsych space is a huge space, and it's important certainly in the elderly as well, where we are really or really concerned about side effects and additive toxicity. And we've all seen, the long-term care patient with 30 meds and 10 of them involve their brain, and the fall risks and all of these things that come about it. Pharmacogenomics, and this is not my, anecdotes. The data is getting stronger every day that really supports we can make positive changes for those patients if we know this information ahead of time. Yep.
So, and that is so critical. And I think it's such a key differentiator in what you're doing, as opposed to again, just filling it, putting it in a system and having it spit out some kind of data. It's this idea of like, what's going to be best for that patient? What's going to be best for that particular outcome and I love the idea around the neuropsych side of it, because there's so many people on all those different drugs and to what effect, right? Robert makes a good point, and it was a point that we were going to talk about. I mentioned to you in the pre-show that I had gotten involved in the 2013 to 2019 range, working with the National Nurses Coalition on improving how the different states saw nurse practitioners, particularly in terms of operating at their highest level of training. And there's a corollary here. People that are not familiar with the work of pharmacists like yourself, people with the depth of background, our life experience with the pharmacist is the pharmacist that's at the local drugstore that dispenses, or in the lab or in the hospital doing dispensing, making sure that the pick system has all the different drugs, and all that's so critically important. But there's so much more to your training and to all these pharmacists training, where they can operate at a much higher level, in the level that they have trained to do. And there's so much value in that. And I would love for you to talk a little bit about just that from a clinical pharmacist perspective, how gratifying that must be. Because, and again, I know that's off topic from what we were talking about, but I think when I think about my audience, and they're hospital leaders, and by the way, if this is the first time you watch the healthcare leadership show, this is the kind of conversations we have. And if you like it, please let us know. Click like on the comments and let us know. But talk a little bit about that, because I think that's when we have a person like yourself, when we have a professional PharmD with this background and this education, who really wants to make the difference in a patient life, and now they can work in this type of environment, what does that look like? I guess that's the question.
Sure. Yeah. I would hope that most folks, tuning in have seen a clinical pharmacist in action, right? As opposed to kind of the behind the drugstore counting pills, dispensing, which again is a vitally important piece of the healthcare system as well. But yes, this evolving space of clinical pharmacy, where pharmacists are putting their hands on people and sitting side by side with providers, respiratory therapists, truly as part of the multidisciplinary team, the benefits of that are overwhelming, and the data bores that out as well. To have a drug specialist at the bedside with you is important. I teach at as adjunct faculty at a number of colleges of medicine, and they get exactly 1 semester of dedicated drug pharmacology, right, in med school. There's so much to know in the world of medicine. Drugs are only increasing, but it's hard to dedicate that time to providers who have to learn so much else, about how to treat people. So it's nice to see this field of clinical pharmacy really rising to that, to say, well, we are drug experts. Let us fill that gap. Let us be the drug experts, not behind a desk somewhere or in the basement of a hospital somewhere, but at the bedside with you or in your clinics or wherever. And pharmacogenomics, again, has been a great field that really emphasizes that, because pharmacists work all over the place in cardiology spaces, in psych spaces, in infectious disease spaces. But maybe no realm of medicine is better suited to leverage pharmacist expertise than the field of pharmacogenomics, because so much of it relies on the foundation understanding of drug metabolism and drug action that pharmacists spend at least 4 years learning, and many of which multiple years of residency and fellowship and all these other ways that you can specialize to be a real clinical pharmacist. So yes, and that's what our team at Aegis is comprised of, is all of these experts who have then further subspecialized into molecular medicine and pharmacogenomics. And that's why we love what we do. And that's why we are really passionate about letting people know pharmacogenomics isn't just something that somebody else does somewhere. It's attainable to everyone. And you don't have to be the expert. You don't have to go back to school and learn genetics medicine to allow your patients to benefit from pharmacogenomics. Whether you're in an emergency room seeing this person for the first time, whether you're a primary care office, whether you are a cardiology office, pharmacogenomics is sort of the great equalizer that touches all areas of medicine. And that will only get wider and wider as an umbrella as we go. And none of those people have to be genetics experts. If you are paired with a genetic expert who can look at all of that information and kick it out to you in a way that is meaningful and actionable to allow you to intervene in that patient in whatever space you're in. So that's our passion really at Aegis Health Services, is letting people know that, this is a great place for clinical pharmacists. And that's the gap that we fill. And how do we partner with you wherever you're at to let pharmacogenomics improve your patients' outcomes?
I love that. And thank you for taking the time to kind of talk about that, because I think it's so critical. And a big shout out to Patrick Allen checking in from Detroit. Patrick catches our shows quite often. And Patrick, glad to have you in the audience. If you have questions for CJ, we're going to have about 7 more minutes on the show. Please post them in the comments and we'll try to address them. One of the things that you and I talked about off the air, and there's Doug is addressing it a bit in the comments, is how's this paid for? It sounds expensive. It sounds like, okay, that's nice to have, but that sounds really expensive. And I don't know if I'm a rural community hospital, is that even in the wheelhouse of our capabilities financially? Not to spend a whole lot of time on that, but I think it's critically important for them to understand the model. CJ, talk about that a little bit. How is this? I guess the question is, why is Medicare and Medicaid, private insurance, why is this really good for them, and how is this reimbursed?
Absolutely. Luckily, the answer is that it's getting paid more and more and more as the data just piles on, that pharmacogenomics testing is actually cost effective if you are an insurance company. It's better to avoid 6 months of trial and error on a psych med. It's better to know that Plavix is not going to protect that stent that your cardiologist just put in. And so you can get on the drug that's going to prevent rethrombosis and save you a $50,000 hospital admission down the road. And the data is pretty clear about this. The last, again, meta-analysis I saw for 2025 was a paper that showed 71 or 73% of all pharmacogenomics testing was cost beneficial. It was cost savings in the long run by reducing ADRs, improving efficacy, getting patients on lower doses that are equally effective, so they maximize efficacy and minimize toxicity. And again, the idea that it's a one-time test. This isn't something that you need to do every 6 months or every 3 months. This happens once and you get benefit from it forever. So again, luckily, payers are starting to wake up to that and see this data and are much more readily starting to pay for it in lots of different forms. It used to be you had to have this whole group together. You had to have this whole process in your health system figured out to get paid. And you had to have a genetics counselor involved, and there had to be all these things. And that has loosened up a bit to make pharmacogenomics more accessible to a wider array of medical sectors or providers in different settings. And not only do insurers like the testing more now and are more willing to pay for the testing itself, they also recognize this radiology gap, luckily. And it's not going to take us 40 years, I don't think, to get there. They're recognizing that paying for a test that drops a 50-page report in somebody's lap doesn't actually turn into improved outcomes, because a lot of that information just stays static because providers don't have the time or expertise to sift through that. So they also recognize that paying for a radiologist, if you were paying for an interpreter, who's a molecular expert, is also worth the cost, because then that allows these patients to see benefits now and reduce costs down the road, through better care today. I'm really hopeful that that's going to continue. Pharmacogenomics is not going away, and it's being more and more recognized as a precision medicine tool, which is where we're all trying to go. There's really nothing else like it. It's not replacing an old technology. It's not, should I use this new one or should I use the old cheap one? Like some diagnostic technologies, it's just new. And the data continues to say that it is as good as it's billed to be, and that it does. It improves outcomes for patients, and it lowers costs for patients and payers. So hopefully we see that continue too as a trend.
Yeah, and I love that. I think, and I've got a show coming up in a couple of weeks with a gentleman named Dunn. We're going to be talking about the difference between just being focused on innovation and transformation to the healthcare delivery side. And I think this fits right in there. It's like there is innovation with the genetics testing, with the ability to do this mapping, if you will, of the patient care delivery, but it transforms, if we will. And when we take that and we personalize it and we get people involved and we get clinical professionals working with people like yourself, then it goes from this innovation that's out there that's great and cool and shiny to transforming how we deliver care. And I love that transition. We only have about 2 more minutes, CJ, and I told you this would get that our 30 minutes always goes by, and it seems like in 15. For healthcare delivery leaders, which is the majority oftentimes of my office, my show and my connections. And by the way, again, for those of you who don't know, if this is the first time you've ever seen the show or connected with me, I'm a serial entrepreneur that works with healthcare companies, both in executive leadership and also business development and leadership development, and have had the opportunity in working with Aegis, which is the company you're a part of. But where should they start if they're like, oh, this sounds like something we need to bring to our company or our organization or our care delivery model? Where's the place to start? Obviously, they need to connect with the people in your team, the Aegis. But what's the first thing they should do in terms of how should they go about it?
Honestly, if this is the first time you're thinking about this at your place or wondering, how could I implement this in my urgent care or wherever you're at, tap into the pharmacy resources around you, because the odds are good that they are aware of this field and understand how practices maybe do this in similar spaces, and they could give you some ideas. And honestly, the other thing, give us a call. I mean, this is what we do at Aegis Health Services. We work with provider groups who aren't doing anything related to pharmacogenomics. And we know labs across the country who do this testing. We've seen operations all across the spectrum on how they do it and how they bill it and how they follow the compliance things. And we've got all that information available to us as well, and would love to partner with you literally wherever you are in your pharmacogenomics journey, even if it's on the starting blocks. That's where we work with people all the time to do education, or to help brainstorm how to bring it to your patients and have it make an impact wherever you're at in the stage of pharmacogenomics game. We pick people up from there and help kind of walk alongside them to get pharmacogenomics up and running in their space.
Awesome. And if you are interested, drop it in the comments, and somebody from Aegis will reach out, or connect with me, send me a DM. We'll get you introduced. CJ, great discussion. I'd love to get you back on the show in a couple months, in a few months, to really talk about, like, what's the next thing here. We've got what we're talking about now. This is not new, but somewhat new in this space, but this is going to grow. This is going to evolve even further over the next 2 to 3 to 5, even further, 7 years. I'd love to get you back on the show. Any last comments? And by the way, if you like the show, please let us know in the comments. Please click like, please share the recording or share the event. This whole show is geared toward getting information out about the amazing work that the people in my network are doing. Any last comments, CJ? Thank you for being on the show. What a great conversation.
Yeah, no, this is terrific. I think the only other thing I'd say, if it hasn't come across yet, is that pharmacogenomics is all of our responsibilities. We silo things in medicine increasingly, specialists in different fields. But pharmacogenomics is a one-time test that we're all sort of responsible for. If you're an infectious disease doctor, you can impact that patient for life by getting pharmacogenomics done for them. If you're primary care, if you're a gerontologist, anywhere you're interacting in the healthcare system, pharmacogenomics pays lifelong dividends for these patients. And so that's the big push that I would make, is that if you think pharmacogenomics is for someone else to worry about and for someone else to order, I'd love to chat to encourage you that doesn't have to be the case, and that it doesn't have to be hard, and that it can be cost beneficial to you and everyone, and all of that. So again, we'd love to connect to people in some different arenas to show how pharmacogenomics could fit in your space too.
Awesome. Great conversation. Thank you for being on the show, CJ. And thank you in the audience for watching the Healthcare Leadership Show with Marion Spears Carr, either live or watch the replay. Please post in the comments. Let us know you're there. And we're glad to be here. Have a great week. I've got a new show coming up next week. I'll be announcing that tomorrow, and the show about innovation will be in 2 weeks. So glad to have you on the show, CJ. Have a great day, and we'll end the stream.
Thanks for having me, Marion. Talk soon.
So, yep.